Good afternoon. I'm glad I was invited. I want to thank Professor Kotsis for his invitation. And my topic is risk reduction in cardiovascular disease in smokers, and we will relate especially to those that are unwilling to smoke. Just first, my disclosures, and we'll start with the basic things that I am sure that everybody knows. The natural history of cardiovascular disease. We have cardiovascular risk factors. We are fully aware of them, and smoking is an important member of this group. And we know that in the beginning, we have only functional changes which are seen as endothelial dysfunction with no structural changes. In this phase, we have decreased small artery compliance, decreased forearm dilatation, and of course, beginning of rise in blood pressure. The next step is associated with structural changes which signify disease. Here we have factors of atherosclerosis and vascular aging, which is called arteriosclerosis. At this stage, we have changes in intima media thickness, retinopathia, microalbuminuria, decreased large artery compliance, and increased pulse pressure. And the next step, we see formation of plaques, calcifications, and organ damage, myocardial infarction, renal failure, and others. The risk factors are divided to three groups. There are modifiable risk factors, which I put a question mark because they are modifiable only in the part of the population, like smoking, obesity, diet. We are all aware of sick patients that continue to be obese, continue smoking, cannot decrease their stress, do not change their physical activity, etc. Non-modifiable, like age, gender, family history, ethnicity, and history of previous end organ damage. And treatable risk factors, which include the risk factors that we are all busy in treating them every day. Now, risk factors, where they are ranked as causes of death, and this is a summary by the WHO, we can see that tobacco use is an honorable member of this group. It's among the major risk factors that we are aware of. Now, we do not have to convince everybody that smoking is bad for your health. Cigarette smoking is an important and reversible risk factor for cardiovascular disease. The incidence of MI is increased. It differs in various studies. In this study, it was sixfold in women and threefold in men who smoke at least 20 cigarettes a day. And an important factor, the risk of MI is proportional to tobacco consumption in both men and women. And it has been even proven that inhalers and non-inhalers differ in their cardiovascular risk. Now, one of the important studies performed, the InterHeart study, showed that smoking accounted for 36% of the population attributable risk of first MI. Smoking causes excess risk by increasing smoking-related disease. Here in this graph, you can see the major diseases associated with smoking. The most impressive is lung cancer, and it continues to climb. By the way, it's the graphs describe a smoker that started to smoke at the age of 20, very frequent, and we can see that there is no decline at any stage in lung cancer. Also, no decline if chronic lung disease. There is an increase also in ischemic heart disease and in stroke. Now, smoking cessation is an extremely important decision. It has been shown that recurrent infarction in a study of smokers who had an MI and quit smoking fell down by 50% within 1 year of smoking cessation. It normalized to that of non-smokers within 2 years. However, many smokers continue to smoke after diagnosis of cardiovascular disease. It has been shown that for about 49% of smokers diagnosed with coronary artery disease continue to smoke. About 57% of smokers continue to smoke after a stroke, and about 72% of smokers diagnosed with peripheral artery disease continue to smoke. So how can we convince those people to stop smoking? This is an important data published by the WHO showing trends in cardiovascular disease mortality in developed countries. Those are European countries. Each color represents another country. You can see the countries below. And what we can see here, that starting in 1980 till 2000, there was a significant decrease in trends in cardiovascular disease mortality rates in developed countries. However, from the year 2000, the lines are almost parallel, very slight decrease in various countries. What happened here? Before the year 2000, we had developments in many areas, new medications, new devices, technology, changes in the approach to coronary angiography, etc. And also understanding and campaigns to the population about the importance of lifestyle change, including smoking, alcohol, activity, diet, etc. However, we can see that we have achieved the majority of the achievements until 2000, and for the last 20 years, the decrease is very, very low. So we have to develop a new approach and to cause further decrease in these morbidities. So what is the objective of harm reduction? Harm reduction is based on the premise that some level of unhealthy behavior is inevitable and therefore targets to minimize the harms people suffer. People make poor lifestyle choices despite suffering negative health effects. Many patients with diabetes continue to overeat and eat unhealthy foods. Many patients with chronic obstructive pulmonary disease continue to smoke. And many patients with ischemic heart disease continue to lead sedentary life and eat unhealthy diets. So we have opportunities of different approaches to harm reduction. It is already successfully applied in many areas. Unhealthy diet, we have statins, we have stents, we have antiaggregants. For skin cancer and sun tanning, we have sunscreen, we have sugar replacements. For unsafe sex, we have condoms, vaccines. And the smoking cessation is by far the best option for smokers. However, it is estimated that more than 1 billion people continue and will continue to smoke in the foreseeable future. The first question that should be raised is harm reduction ethical? We know that at least 7 out of 10 causes of death are related directly to lifestyle and behavior. Lifestyle is the most effective way to minimize the health burden. However, how can a doctor balance the two discordant concepts? First, a patient's freedom to choose unhealthy behavior. You cannot force your patients to do things. You can advise and try to convince. Second, a doctor is focused on providing the best care. So if we have a patient that cannot stop smoking and smokes 20 cigarettes a day, and we will try to convince him to lower to 10 cigarettes a day, we are compromising. This is not the best care, and it won't be acceptable by many physicians. The harm reductions focuses on harmful outcome of behavior rather than the behavior itself. You cannot stop a person from taking illicit drugs. However, you can assist him in preventing overdosing and preventing infections. People who suffer from the effects of entrenched habits may be unwilling or unable to change. And this raises the possibility of a beneficial role of harm reduction. Now let's see what happens when we smoke. Tobacco smoke contains more than 6,000 chemicals as well as ultrafine particles. 93 of them have been listed by the FDA as harmful and potentially harmful constituents, and the majority as classified as carcinogens or potential carcinogens. Now, this is a picture of a cigarette. This is the top of the end of the cigarette when the fire is, and this is the filter. If you measure the temperatures along the cigarettes until the tip, you will find this picture. So at the tip of the cigarettes, we have temperatures that arrive to 750 degrees of Celsius. It goes on from left to right and increases when you come farther to the right, farther close to the fire. At a degree which is higher than 750 degrees Celsius, combustion occurs. Combustion is burning of the tobacco, and this is a process that releases the majority of the toxic substances to the lungs and the carcinogenic substances to the whole body. Now, in this slide, you can see that if you take tobacco and heat it or burn it, the higher the temperature, the higher the level of the toxic and carcinogenic constituents. If you lower the temperature, the lower the amount of these toxic and carcinogenic substances. Here we have a table of a graph of combustion and no combustion in tobacco products. So all those that are associated with combustion, burning process of the cigarette, of the tobacco, are with very high combined risk score for disease. This is a combustible cigarette, the cut tobacco, cigarillos, Western pipe tobacco, cigars. However, you should notice that when there is no combustion, the levels of the risk are significantly lower, approaching to almost zero. This is a picture of several options for somebody that cannot stop smoking, but we can assist him in reducing the harm. The snus is a tobacco type used mainly in Scandinavia, electronic cigarettes, and heated tobacco products. Of course, many products are in each group, especially electronic cigarettes and heated tobacco products. Some of them are better, some of them are really investigated, some are not. So we should consider each of them separately. Now, an independent study of the tobacco heating system emissions performed in Germany has shown that in a tobacco heating system, nicotine yield is comparable. And this is important because the major factor in inability to quit smoking is addiction to nicotine. If you take out the nicotine, the percentage of failures of smoking cessation will be very high. So if you supply the nicotine without the toxic and carcinogenic substances, you have higher probability of remaining without cigarettes. Now, in the tobacco heating system, there is substantially reduced level of aldehydes, and the levels of major carcinogens are markedly reduced. This is another study performed by the FDA in the Southeast Laboratory in the US. And the conclusion of this study, you can see here, the yellow part is the part of the toxic substances in tobacco heating systems, comparing to 100%, which is found in smoking a conventional cigarette. So in this substance, in this tobacco heating system, in this case, it was the IQOS, there was no combustion, no burning of tobacco, and the reduced levels of toxicants than cigarettes were found. The smokers who switched completely reduced their exposure to toxicants. There is lower toxic potential, and although risk reduction has not yet been demonstrated, a substantial and measurable reduction in morbidity and mortality is reasonably likely in subsequent studies. Alternatives to smoking and harm reduction. Alternatives to smoking are recognized in some countries. In the UK, the health authorities report vaping as a method that allows smokers to quit smoking. So we have evidence that vaping is use of electronic cigarettes, is enhancing the percentage of quitters in smoking. In Japan, cigarette sales have fallen by 1/3 since tobacco heating system entered the market. In Sweden, there is a vast usage of snus, and the smoking prevalence in Sweden is the lowest in the EU. The use of snus or oral tobacco products is the highest, and this correlates with the lowest mortality rate in the EU from lung cancer and from smoking-related diseases. In the USA, the FDA endorsed the harm reduction approach by ensuring that new tobacco products are tested prior to being commercialized, and that tobacco products marketed with claim of reduced exposure are based on scientific evidence. So what should be our approach? First of all, we have to continue and educate for optimal lifestyle from early childhood. Smoking cessation for sure is the far best option for any smoker. Maximal use of all possible harm reduction abilities present should be used. Governmental adoption and support and research of implementation of harm reduction processes is needed. And we need an open mind to promote and adapt various harm reduction in all fields of cardiovascular risk factors. Thank you.